All right, behavioral therapy. This is my advisor, Dr. Charles Mervitz. I love the man. He's a great guy. He used to say this all the time. We're pretty good at engineering and building roads. We don't need to learn how to build a better road. Good luck changing people's behavior. All right? Charles Mervitz. Thank you. First, structure. We got to build structure around these individuals, around our patients. Regular visits are important, 1 to 4 times a month. Connectivity. Okay, we have to have contact with people. All right? Why is that? Because when people go off their meal plan, all right, when they're being naughty and they're not doing what they're supposed to do, what they do is they do it in private. Of course. You're not going through a drive-through with your dietitian. Hey, come on. Want to join me for dinner? They're going to do it in private, okay? Because they know they're not supposed to be doing it. So you have to find a way to keep them coming. So follow-up care is key. Reaching out, emails, groups, follow-up groups are important. So you got to create connectivity, absolutely critical, okay? This is important. Do they have a sustaining meal plan? Okay, they have a diet. They've lost weight on some diet, but do they have a meal plan? Okay, how many of our patients say, I know what to eat? Everybody knows what to eat, okay? But do they know what to eat that day? Okay, sometimes yes, sometimes I know. Do they want to eat it that day? Not necessarily. So what we do know, there's some research out there that if you have 1 to 2 meal replacements as part of a sustaining meal plan, it's brilliant. It's a great idea. Why is that? Simplify decisions, reduce temptation, okay? So you got to have your patients know their sustaining meal plan in and out.
So all inflammatory triggers activate signals that lead to a response in our body. And this is chronic inflammation is when we lose that tolerance. So this was published in a European journal in 2006, which shows that in most obese patients, obesity is associated with a low-grade inflammation, and it appears to be coming from the white adipose tissue, resulting from chronic activation of the immune system and subsequently leads to insulin resistance, impaired glucose tolerance, and eventual diabetes. And so when we get into the metabolic syndrome, we can see oftentimes that inflammation is that underlying source.
Over the years, I've come up with a list of 10 common characteristics of successful centers. Does your program have these characteristics in place? I want you to go on this slide, and as I read them off, you check if you or your staff have these in place. Because in my years of working with customers, these are a lot of the key elements. Passionate leadership and staff. The first 2 are going to be the most important. Are you passionate, and is your staff passionate about weight management? Because if you're not, the programs that are getting your patients. You have to be motivated, you have to be committed, you have to be passionate to running a program. Patient results. I can't tell you how many programs I walk into across the country, and I ask them, well, what type of results you have? And they sort of fumble around. They don't know really what type of results they have. Geez, what's your average weight loss on your particular program? They're not sure. So you need to be able to keep data on, are your patients losing weight? Because if they're not going to be with you very long. As part of the comprehensive nature of structured programs, this slide provides you some of the materials and protocols put in place by successful centers. Some of the elements include meal plans, food diary forms, mandatory use of meal replacement products and protein supplements, weekly patient office visits. Again, somebody actually asked me this morning, how often should we see patients? And we recommend once weekly. I can't tell you how many programs I've been to across the country that say, oh, geez, we only see them once monthly. Once monthly is not enough. You're not going to have a program. Once monthly, they're looking for accountability. Patients are looking for accountability, follow-up, coaching, mentoring, education. And if you're not providing it, you're just saying, here's a prescription or here's a plan, I'll see you in a month. I guarantee you, within a day or 2, they're driving right to Dunkin' Donuts. And you're not even going to know it for the next 3.5 weeks. So we recommend at least seeing them once weekly.
We're always always saying, oh, our patients. Oh yes, Mary Jo, can I talk to you? My patient next door. Let me tell you what happened. Let me tell you what happened. That's you and I. And if you carry any weight with you at all, you know how difficult it is to feel good about your body, to feel sexy. And what's really sad is the majority, and I'm talking 40 to 60% of all obese women. I know there's not a lot of literature about this, but there's enough for sex therapists to really make a case, are sexually abused. And I run a 12-step food addiction group, and 9 out of 10 of the members have been sexually abused. They happen to be women. And you might say to yourself, why in the world would that be? And why would we continue to be doing bariatric surgery or other weight loss interventions without addressing this? Because they don't tell you, because you don't ask. And it's as simple as that. And so I think it's something we really all have to start thinking about. Why are our patients overweight? And why aren't they successful with medical interventions and surgery? The people I evaluate now for bariatric surgery have had 3 different weight loss surgeries. And guess what? They have the same pattern. They lose about 50 to 100 pounds and they gain it back. The reason is we never got at underneath what is going on with it. So I know most of you do not have access or time to do this. However, if you do, then this is a worthwhile sheet you could give them. Just have these questions on it. You don't, if you're embarrassed to talk about sex, then you can just have your counselor or your nurse in your office. Usually they will know who to give it to or who to go through it. There's nothing bad about any of these, but I promise you, you will alert yourself to a lot of people who may be successful with whatever plan you're going to try to intervene with this time, because this will tell you what you need to know. Sexuality, intimacy, is very wrapped in to self-esteem and motivation. You know, we've been telling women for a long time, you want to look good, you want to look sexy in front of your girlfriends, you want your husband to love you again. We're missing it. That superficial media stuff. What we need to say is, what happened to you in the past? How do you feel about your sexuality? How does your partner feel about your sexuality? My patients are actually putting towels around the glass shower door. Their partner hasn't seen them for 16 years naked. Do you think that's a problem? Does anybody in here think that's a problem? That's a big problem if you have that much shame. What can cause that?
The development of obesity is delayed usually by a generation, because what happens is that the influences of the environment take time to develop. You get an immediate influence of the environment, and we'll come back to this. You get a developmental influence. How do we know this? Because if you have a group of animals or a group of people with the same genetics, but those individuals, animals or people, with the same genetics, born to a mother with more severe obesity or diabetes, are going to get more severe obesity themselves. So if you just sort of clone people generation after generation, the obesity would get worse and worse and worse and worse, because the first generation would be born to a mom who is thin, and the second generation would be born to a mom who's a little heavier, and the third generation to a mom who is heavier still. And you just keep escalating the rate of obesity, having nothing to do with genetics, having to do with the environment when the individual is in utero. So you have to say that the most profound effects of the environment on obesity and these correlations that everybody talks about take time to develop, and that, again, comes back to the notion. The biggest growth of obesity is the last 30 years, or 35 years, but the biggest the cause of obesity started 100 years before that. It's not a problem of eating too much. I'm going to come back to this for the rest of the talk. This is a problem of mismatch between how many calories go in and how many calories go out, and that mismatch is not determined by people's choice, generally.